So technically, my arteries did connect to the right place. However, it was in the wrong location, and my pulmonary artery didn't have a valve, so it didn't really matter anyway. Hello everybody and welcome to my channel. My name is Marissa and you're watching Life After the Fontan. For those of you that are new here, welcome. I'm a 24-year-old living with complex congenital heart disease, documenting my life with a single ventricle Fontan palliation. Welcome. For those that are returning also, welcome. Thank you so much for coming back. Please remember to like this video, subscribe to my channel, and turn on your notification bell if you'd like to be one of the first to watch my upcoming videos. So today's video is probably long overdue. This was actually one of the first videos I had planned on posting. However, my surgery and cardiac cath got in the way and it had to be held off until today, actually. So we're finally going to be talking about my heart structure, the defects I was specifically born with, and the 3 surgeries that I had, and what complications you can expect down the line. We're also going to be touching a little upon fetal circulation, just because in order to understand my surgeries, it's also important to understand fetal circulation as well, just a little bit. Now, fair warning, this video is probably going to be pretty medically based with a lot of medical terms, which I will explain. A lot of sciencey stuff going on here, but not all of my videos will be like that. So let's get started. As we've talked about before, congenital heart defects, the #1 birth defect occurring in every 1 out of 100 births, is really a structural malformation that occurs while a child is developing in their utero. There's usually no cause. There can be sometimes due to autoimmune disorders and other things. However, for many cases, the cause is not known. So when a baby is developing in utero, and this goes for all developing babies, whether they have congenital heart defects or not, they have a few extra little holes or passageways or shunts, if you want to call it, in their heart that really allows their blood to bypass their lungs. Your lungs basically aren't working during fetal development. So the first hole we'll talk about is something known as a foramen ovale. It's a small hole in between the 2 atria, between your left and right atria. This hole would close a few hours after birth usually. The foramen ovale allows mixing of blood from the left to the right, shunting, in order to bypass fetal pulmonary circulation. So then once a baby is born and they begin to breathe on their own, this hole begins to close. If it were not to close, that's actually known as a congenital heart defect called patent foramen ovale, or PFO. The second passageway is known as the ductus arteriosus, which connects the pulmonary artery to your aorta. This is also allowing the blood to bypass the lungs. And then once a baby starts breathing after being born, that hole usually closes pretty quickly. That hole does not close on its own. It is once again known as a congenital heart defect, patent ductus arteriosus, or PDA. And also important to note, there are a lot of congenital heart defects that require that passageway to be patent, to be open, in order to adequately perfuse your body and get your oxygen where it needs to be. So many times a baby may be born, and if they need that hole to survive until their first surgery, they'll be placed on a medication called prostaglandins in order to keep their patent ductus arteriosus patent. So just to summarize, the ductus arteriosus and the foramen ovale are there to bypass pulmonary circulation in the fetus. Once one is born and starts breathing, both of these holes close. However, it's important to keep the ductus arteriosus, or ductus, we may call it, open sometimes when a baby has certain congenital heart defects that are limiting their pulmonary blood flow. So next I would like to talk about my 6 congenital heart defects. So my first congenital heart defect that I usually list off in a row is known as pulmonary atresia. I have a picture here from Boston Children's Hospital to better explain a normal heart versus one with pulmonary atresia. Now remember, many congenital heart defects occur in combinations of 2 or more. This specific picture really is just shown to highlight the pulmonary atresia that we're about to discuss. My pulmonary atresia came along with 5 other defects, so my heart did look very different than this. So your pulmonary valve connects your right ventricle to your pulmonary artery, so that way your blood can be pumped out to your lungs. Now, atresia means that the valve does not open. It's basically not there. So when you think about it, there was really no opening to send blood to the lungs with pulmonary atresia. I, however, was also born with a ventricular septal defect. A ventricular septal defect is a hole in between your 2 bottom chambers, your ventricles. This allowed for mixing of the blood, and by placing me on prostaglandins, the medication we talked about earlier, that blood was able to be mixed and then get to where it kind of needed to be, even without my pulmonary valve. So my next 2 defects kind of fall into one. They're known as transposition of the great arteries and ventricular inversion. That ventricular inversion basically means that my physiologic right ventricle was actually flipped and where my left ventricle should have been, and vice versa. Now, the reason that's important is because your ventricular muscles differ in size depending on whether it needs to pump blood all the way through your body, it would need to be bigger, or pump blood just over to your lungs, so it would be a little smaller. Transposition of the great arteries is really referring to your aorta and your pulmonary artery, where the pulmonary artery usually connects to your right ventricle and your aorta connects to your left ventricle. Mine were transposed, they were switched. They usually crisscross in a normal heart, but instead they went straight down. However, just to make things a little more complicated, mine was considered congenitally corrected because of that ventricular inversion. So technically, my arteries did connect to the right place. However, it was in the wrong location, and my pulmonary artery didn't have a valve, so it didn't really matter anyway. I was also born with bilateral superior vena cavas. Basically, your superior and inferior vena cava is a large vessel that runs along the right side of your heart into your right atrium. The superior vena cava drains blood from your upper body, and the inferior vena cava drains blood from your lower body. So basically, instead of only having one on one side, I have the superior vena cava on both. So that's just draining blood from both sides of the body. Lastly, I have what's called Dextrocardia, so instead of sitting on the left side of my chest as normal, my heart is actually positioned towards the right side of my chest. In recent years, however, it's really been a consideration upon whether I have something called mesocardia instead of dextrocardia, which would mean that my heart sits right under my sternum instead of on either side of my chest. Now, for anybody who is at all familiar with congenital heart defect care, you may guess that having mesocardia, as we think, really impacts my ability to have echocardiograms because my heart sits right below my sternum. So every time I get an echo, the results usually say very poor windows, unable to be seen, unable to be seen. Hopefully nothing's changed, because if it did, we couldn't see it anyway. So many people are surprised when they hear that my surgeon, Dr. Marshall Jacobs, decided to go down the single ventricle pathway because I was born with 2 fully developed ventricles. I possibly could have had a dual ventricle repair, and I wouldn't face the complications that the Fontan does down the line. However, who knows if that would have worked. My hole between my bottom chambers, my ventricular septal defect, was really large. I didn't have a pulmonary valve. My arteries were already in the incorrect spot. There was a lot that was stacking against a dual ventricle repair, which is why they went down a single ventricle repair pathway. For those that are unaware, the Fontan surgery is a staged surgery that usually occurs in 3 separate surgeries. The first stage is usually some form of a shunt, whether it be a BT shunt or a Sano shunt. This could also sometimes be known as a modified Norwood procedure. Now, Dr. Norwood, actually today as I am filming this video, they've announced that he passed away, which is really sad because he was a pioneer in the congenital heart defect community, and my surgeon trained directly under him. So I can't even just credit my own surgeon, but also Dr. Norwood for saving my life. So rest in peace, Dr. Norwood. Thank you for all that you've done for the congenital heart defect community. So this first picture from the Children's Hospital of Philadelphia is perfect because it shows a BT shunt. A Blalock-Taussig shunt connects the pulmonary artery to the subclavian artery coming off of your aorta. As you can understand, this was important because I was missing my pulmonary valve. So when blood was sent out of my heart through my aorta, some of it still went through that BT shunt and still went to my lungs to pick up oxygen that could then be delivered to the rest of my body. A Sano shunt is similar, however it's connected in different locations. That one goes from the pulmonary artery to your right ventricle. So what's interesting about the BT shunt, as compared to what we discussed earlier, is that it really takes over the role of that patent ductus arteriosus, which was earlier connecting your aorta to your pulmonary artery. I do want to point out that this image is of a heart with hypoplastic left heart syndrome. So again, that's not what I was born with. However, it's the surgical pathway I went down, so it's the closest thing that I have to show you guys to it. So the second stage surgery is either known as a Glenn or a Hemi-Fontan. There are small differences with either. Basically with that one, the superior vena cava, which is what drains blood from the top of the body into the heart, is connected to the pulmonary artery. So that blood is drained from the top of your body and then it goes straight to your lungs, and it does not stop at your heart yet. And lastly, this is where I'll get into the most detail with explaining, is the Fontan Completion. I had this final surgery when I was just under 2 years old, at 22 months old. What happens is that your pulmonary artery, which was previously connected to your superior vena cava, is also then connected to your inferior vena cava. And then what happens is that fenestrations are made, which are really little pop-off holes in between your right atrium and the vena cava, which allows for mixing of blood, but really just a pop-off pathway for extra pressures. Many times fenestrations will close on their own down the line. Sometimes fenestrations need to be closed due to desaturations because it does cause mixing of blood. Other times fenestrations may need to be created if they have closed or weren't created originally because increased Fontan pressures. So a Fontan circulation, as you can see, is really just by gravity. Instead of having two sets of circulatory pathways between your pulmonary circulation and your systemic circulation, instead you really just have one. So to put it into simpler terms, we'll say my blood starts in my right atrium. It came there from the lungs. There's a hole between the right atrium and the left atrium that is surgically created. So that's really just one big chamber at the top. That blood then goes down many times into the single ventricle. Myself personally, I have both, just with a big hole in between them. Some people only have one due to the other being underdeveloped. So it goes from the atria into the ventricles. The ventricles then pump the blood out of your aorta. Upon leaving your aorta, blood is returned through the superior and inferior vena cava. From the superior and inferior vena cava, blood is taken to your pulmonary artery, which then goes to your lungs, and then your lungs send blood back to your atria. Usually a heart has two different sides pumping to two different locations, so this one's going one way, that one's going the other way, but this one is really just one loop. So there are quite a few complications that a Fontan patient can face down the line. And I'm speaking in terms of adult patients like myself. One of the most common findings with adult Fontan patients is something known as Fontan-associated liver disease. This is due to higher pressures within your Fontan circulation. And basically that higher pressure is going into your liver very hard. It's kind of funny to think about because a lot of times Fontan patients tend to have lower blood pressures just because of how their heart is set up. Fontan-associated liver disease can really be described as congestion within the liver due to these higher pressures. It leads to fibrosis and then ultimately cirrhosis. The good news is that your Fontan-associated liver disease is said to be stable as long as one's heart is stable. What I've always been told, because I do have Fontan-associated liver disease, is that my liver disease should not worsen unless my heart does at some point. I don't have any symptoms from my liver disease, though I know other CHDers that have. For this specific form of liver disease, it's important to have follow-up testing every 6 months in regards to liver labs, so blood work, as well as ultrasounds. The scary part about having Fontan-associated liver disease is that somebody with this diagnosis is at a much higher likelihood of developing hepatocellular carcinoma in the future, which is liver cancer. Those ultrasounds every 6 months serve to look for lesions and different spots on the liver that shouldn't be there. Another complication of the Fontan procedure, one which I was unaware of until it was finally diagnosed, is something called Tcell lymphopenia related to the Fontan. It kind of is similar to the liver disorder where the higher internal pressures impacts another organ system. However, in this case, the higher pressures in my circulatory system really don't allow my lymphatic system, which usually creates all of your white blood cells to fight off infections, specifically in this case. The higher pressures does not allow your lymphatic system to secrete those white blood cells, in my case T cells. Another way to describe it is that my body is making the proper number of T cells that it needs, but they're stuck. They can't get out because the pressure is so hard on the lymphatic system. So with that, I'm really more susceptible to certain illnesses, and it's actually something that I'm going to talk a lot more about in one of my future videos titled My Journey to Becoming a Nurse. So keep your eyes peeled for that one if you're interested in learning more about T-cell lymphopenia. Fontan patients are also likely to experience some type of arrhythmia down the line, whether it be atrial or ventricular arrhythmias, basically abnormal heart rhythms either occurring from the top or the bottom chamber of your heart. And also due to the strain on that single ventricle, heart failure is something that is often looked at down the line. I know for a lot of adult patients that the talk of transplant is usually brought on at some point. As of now, my cardiologist doesn't foresee that happening in the future, but I deal with things as they come, so I'm not even worried about the possibility of that at this point. Some other things worth noting related to the Fontan procedure. Mental health disorders are very common, not even specific to the Fontan, but just to the congenital heart defect population. Somebody with a congenital heart defect is more likely to experience depression, PTSD, and anxiety down the line. So it's really important for a CHDer, or really anyone with a chronic illness, but a CHDer, to be screened for signs of mental illness and to seek prompt treatment when necessary. Reproduction is usually a big question in the Fontan population. There are some Fontaners that I know that have successfully had children of their own. There are others that I know have not been able to have their own children and seeked alternative options. Pregnancy in itself puts a lot of strain on a healthy heart because your blood volume doubles in pregnancy along with a few other things. If you already have a heart with a single ventricle, adding double the blood could really strain one's heart and possibly lead to heart failure down the line. I get the question all the time if I'll be able to have children in the future. As of now, we're thinking it's a yes, but we will see. Before then, I'll undergo a lot of diagnostic testing just to make sure my heart is the healthiest that it can possibly be before I put it under that strain. Exercise intolerance is common in Fontan patients just because the pulmonary circulation isn't as ideal as one would be in a normal heart. Low oxygen levels can also be seen with Fontans down the line as well. So the Fontan procedure sounds really scary, especially to new parents who either thought they were having a healthy child and just learned about their baby's congenital heart defects, or they're just learning about the lifelong implications of having the Fontan procedure. It can be really scary because there are so many unknowns. We're really just now learning more about the Fontan-associated liver disease and pregnancy in the Fontan and Tcell issues in the Fontan, just for examples. It's important to remember that though two patients may have similar diagnoses in the same surgery, no patient is the same. One may have no complications and another may have a lot of complications, and there are a lot of unknown factors usually that can lead to this, as well as what one's specific defects were prior to undergoing surgery. So I hope I was able to explain my 6 congenital heart defects, my 3 open heart surgeries, and a little bit about fetal circulation in order to allow all of you guys to understand it. I also think it's really important to discuss the complications of the Fontan, not to scare anyone, but to prove that it's not just a congenital heart defect. It's really congenital heart disease. It impacts your whole being. It impacts more organs than just your heart. So it's really important to look at it in a holistic perspective and treat the whole patient instead of just the heart. If you have any questions related to this video or comments or concerns, please comment down below. Again, I do want to say that all of the images I showed earlier were not from me. None of them are my property. They were taken from Boston Children's Hospital, the Adult Congenital Heart Association, the American Heart Association, and the Children's Hospital of Philadelphia. And I will link websites to all of those sites down below in the description box. I hope you enjoyed this video and thank you so much for watching.